And so I think they generally achieve the same thing, which is identifying what's happening physiologically during sleep, because that's what you want to know, versus your awake assessments, which may be limited. And so with DICE, you're taking a look at the airway by way of a scope while the patient's asleep, and you can see at the different levels what's happening. So you can see concentric pharyngeal collapse, you can see what's happening with the tongue, with the tongue base, and so it gives you that assessment of the different structures that you might be able to address surgically in those children who are either CPAP intolerant or non-compliant. And then it does it sort of one level at a time. Whereas with Cine MRI, you can see all of those levels. And the additional benefit of Cine is you will also get that structural assessment of the brainstem.
I have a question for Manuela as well. You went through a lot of different artifacts and scoring, and I usually ask you lots of questions when you score my studies when I have issues that come up. What do you think are like some of the more common artifacts you're looking at during the pediatric studies?
I look, for example, for them. So the impedance should be good. I look for oral breathing in pediatrics, especially at CO2 waveform. ECG artifact is not very common, but for central apneas, for sure, cardiopulmonary oscillation, periodic breathing.
I think the other one that I tend to see is the oximeter drops out.
Oximeter artifacts also. I remove them when I notice. False desaturations. When if the patient doesn't have like a cardiac or a pulmonary problem, it's not normal to be on 90% for oximetry. So usually the technologist is checking with the portable oximeter.
I have two questions from Manuela.
Okay.
Thank you, Manuela, so much. Both questions are very, very practical. As a community physician, when you don't have readily available or not available at all CPAP titration for young children, is it fair to start CPAP therapy, like let's say 4 to 6 pressure with close monthly follow-up and see if they need fire? Is it a right, or what is your suggestion? And another question I have, also very, very basic practical question, MRI. So I feel like when there is residual severe apnea after surgery, you want to get to the bottom of what's going on, and I feel like it's better maybe ENT doctors or the MRI, because the results come to them where structural abnormality found, of course, PI malformation. So the question is, where do I send, or whom do I ask to do MRI? Do I just do it myself and see results? And also where to send them? Because again, young population, it needs anesthesia. So maybe I'll leave this comment because you work with sick kids. Or what do I do? Do I send to pediatrician because they have their pathways? How it's better to approach? Thank you.
One more question to follow on that is, so do you send them for Cine MRI or regular MRI? Where did we get this Cine MRI to be done? What is the difference between the two?
Yeah. Okay, so perfect. I guess the first two questions. The first was, given the paucity of getting sleep studies, including CPAP titration studies, can we start them on APAP, I guess is the question, safely? And then the second part of that question is ordering the MRIs in these patients who have, I guess, significant OSA that we don't expect, or other abnormalities on the sleep study, and who should be ordering the MRI and where should it be done, given the challenges that some of these younger kids might need sedation. And then the third question, I guess, is the difference between MRIs and Cine MRIs. And so maybe I'll tackle this, but my sick kids guru is right next to me. So my first, I guess the first question is around the APAP. I think I'm very comfortable with just doing APAP in some of these, even in the younger kids. And usually I do them starting at around 4 to 5 years of age. And I actually would recommend like a wider range than 4 to 6. I would just do like 5 to 10 or 4 to 9, depending on the body habitus, depending on why you think they're having these issues. And then I generally try to get a download, or I generally try to arrange a follow-up within 6 to 8 weeks of starting CPAP, and that gives them about a week to start getting used to, or I guess even get the CPAP in check, start getting used to it, and then for me to have some meaningful data to go through. And so I usually ask for a 1 month download once they start, do the 6 to 8 week follow-ups, review the download with them, review any issues with adherence. And then I guess best practice from that point is at some point you should get a CPAP titration study. And then generally, I think our practice is to try and do it 4 to 6 months after the child's become adherent to CPAP. And then the second part of that question is the MRIs. I think I'd be a bit nervous. Maybe there are some ENTs in the room, but I'd be a bit nervous leaving that portion to ENT to order. I feel like I would order it myself. The problem with the MRIs is you're going to get to the brain. You may not get to the neck and the upper airway. So you might not always pick up adenoidal issues or palatine tonsillar hypertrophy. And so it's usually what you're looking for is CNS abnormalities. And so I think I would organize it myself and then direct to neurosurge or ENT or plastics, depending on what you see. And where to organize, I'm also trying to figure that out, and maybe I'd be curious to see where Sunny used to send them before he went to Sick Kids from here. But my preference right now is to just send to Sick Kids for that reason of just familiarity with the system there, but also the sedation piece and whatnot. And I find families are usually pretty comfortable going down there. I've done a couple in the community, but mostly I think I've been referring down to Sick Kids. And then the piece about the difference between the MRI and the CNE MRI. So the standard MRI brain, you're looking for CNS abnormalities, and so it's a static image where you'll basically see if there's any issues. But the CNE MRI will give you that piece of the dynamic nature of where is the obstruction when you're wondering about other sites of obstruction, or I guess multiple sites of obstruction. And so it's done completely different with some level of sedation to try and mimic stage 2 sleep, and you're trying to see in real time where there's issues of obstruction. So I think CNE MRI is more useful for looking at airway abnormalities to explain persistent OSA, whereas the MRI brain is more used to see if there's CNS lesions. Any comment on the MRI piece?
No, I agree with all of that. Really, the to go back to from the beginning, the use of APAP, I think I would just, as a word of caution, know that the algorithms that you're going to get on that download are validated for adults, and so they might not reliably be identifying events in children, and so you may be reassured. And so just monitoring that child clinically would be also very important. You've got the download in front of you, but you've got a child who's persistently symptomatic. You might be wanting to do that CPAP titration sooner than later. But otherwise, I agree with the approach. I mean, using a wider range and eventually knowing that you want to get that CPAP titration to be sure that what you're getting on your download reflects what's happening. For the MRI, I think organizing it where you can get it done the fastest for that particular patient is probably reasonable. So if you've got like a 10-year-old cooperative patient here and you can get the MRI next door in 3 months, that's reasonable. If you've got a 2-year-old that needs sedation, then you want to do that at a pediatric center. And I mean, the different places that I had done MRIs when I was in the community would be at Etobicoke and Markham and Brampton, and I can't remember their age cutoffs, but each site will have an age cutoff where they would might not be comfortable doing the sedation. So that I would say it's reasonable to see what's accessible for the particular patient you have, and then for the CNE MRI, I think and then ENT. Yes, I wouldn't leave the MRI to ENT because the purpose of a structural MRI is not to assess the airway. It is really to assess for CNS lesions. The airway assessment, if we're asking ENT to assess an airway, my expectation would be that they're scoping the patient. So that would be a far more informative assessment of the airway. And then the CNE MRI, the question about how do you order it? So it's a highly specialized test that really is just ordered, at least at our institution, by the ENT sleep team that's doing that multi-D clinic, because that surgeon is the only one that's going to do anything about those findings, because it's really looking at what advanced surgical options are there for this particular child.
So like the CME MRI is like watching the movement, right?
That's right.
Almost like frozen.
That's right.
So can you do that on like the patient has swallowing problem with the esophagus?
It's a good question for a gastroenterologist. I have no idea. Yeah, I'm not. I'm not familiar with CME MRI being used for other things. I actually don't know.
think it should be applicable to other systems.
I think it could. I think the other challenge is you have to find the radio or MRI contrast agent to swallow, which they could gastrograph in. But I've never heard of it being done. It would be the GI docs that do that. I think they like their fluoroscopy. It's just as easy, right, and more accessible. So I had it.
I want to go back to what you just said about the APAP, and there's no real algorithm that deals with children, right? What goes through your mind when you're trying to interpret those numbers when you do give it to a child, let's say 12 or something? Like, are you thinking it's going to overestimate, underestimate, pressures too high, too low, like, or you just kind of wing it?
I don't know that there's enough actual literature to know which way to correct, so to speak.
Yeah.
I would suspect that it is going to underestimate pediatric events.
Do you take like clinical outcomes, like if they're still sleepy or if they're still tired?
100%.
You would
Yeah. So if that,
underestimating.
so that's what I was. If I wasn't clear, that's what I was trying to get at earlier, which is like following them clinically. So if you've got someone who's still clinically quite symptomatic, despite a download looking like things are good, that's a child you probably want to get in the lab sooner than later for the CPAP titration. Yeah. So the importance of sort of monitoring them clinically and not relying on them alone. Sure.
So sometimes machine doesn't reflect the control, doesn't keep it working.
Right.
And those like specifically act conversations with. So sometimes it can be